Hi, you're watching DNA Today, a multi-award winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor, and your host.
We are glimpsing into the future of healthcare. Today, we're talking to Dr. Matthew Rabinowitz, a true pioneer in genetics, diagnostics, and AI, who's been at the forefront of transforming how we approach health and medicine. Dr. Rabinowitz isn't just a scientist. He's a visionary who's helped create groundbreaking technologies, from revolutionizing patient care to tracking cancer through blood tests. He was even named R&D Leader of the Year by R&D World in 2024. Now he's tackling preventative genomic medicine, showing us how tools like whole genome sequencing and polygenic risk scores are turning healthcare from reactive to proactive. Thank you so much, Matthew, for coming on the show. I'm excited. We're going to be diving into preventative genomic medicine. And as I was saying in the intro, prevention is so much better than treatment or reacting. So I really hope that our field in genetics and genomics can more focus on this. But I figured I'd start the conversation out. Right? Exactly. Yeah. So if we could do that, imagine how much less we would have to do in treatment. And my first question was about your thoughts on how whole genome sequencing has transformed the way we understand health risk, carrier status, ancestry. So what are your thoughts on just how preventative genomics has been able to grow through having whole genome sequencing and all the data that we've been able to get from whole genome sequencing in the past few years?
I don't think whole genome sequencing has transformed our understanding yet, because it's only become cost competitive with other approaches recently. So you've just had the UK Biobank in the last year put whole genome sequencing up instead of microarray data or exome sequencing. The paradigm is changing the way we expected it to. So, everyone knows that genome sequencing costs are coming down faster than the Moore's law curve, which says that computational power doubles every 18 months, roughly, in the same cost. Genomic sequencing was much faster than that. It has had moments when it stayed roughly level based on the competitive landscape with companies that I won't go into mentioning here. But in general, it has moved in the direction that we expected, faster than Moore's law. We sort of set up MyOme as a sister company to Natera with the expectation that at some point it would be roughly similar COGS to run cost of goods sold, to run a whole genome sequence instead of a targeted genetic panel. So instead of these multiple different protocols that you run in a lab to do carrier screening, or, for example, a neurodevelopmental genetic testing, or even kidney genetic tests or liver genetic tests, or any of these targeted genetic panels, it would be pretty similar to run a whole genome. We could get the structural variants and the pseudogenes and all the difficult variations from a whole genome, possibly using long read sequencing as well, without requiring all these specialty protocols. And you would be almost the same coverage as you get with all these specialty protocols for the targeted panel. And at that point, instead of running these targeted tests, you can run a whole genome for a particular indication, and then you've got the germline genetics pretty much for life. And you can offer all sorts of additional clinical insights off that whole genome. So we're kind of at that point now. The cost of running a whole genome, depending on your depth of sequencing, is, $100 to $200. Higher than that if you're doing a, somatic whole genome. But it's kind of at the point now that you're getting close to the similar COGS of the targeted panels. So I think the process of a whole lot more insights being revealed is just beginning to start. But as a business, I think the business of doing whole genome sequencing in replacement of exomes and targeted panels, that's just taking off.
And it's exciting to see because it makes sense. Let's get a bunch of data, and then we can go back to that data to garner whatever information we're looking for. So, which I'm taking a little bit of a leap from what you said, but that I could have my genome sequenced maybe when I was 10 years old. I'm 29 now. And now that I'm of reproductive age, we could go back to that and say, all right, well, what am I a carrier of, where I've got to test my partner or sperm donor? And then when I'm even older, okay, well, Is there any cancer risk that, I need to be looking at? And just keep going back to that. I think there's a lot of value there, especially in the prevention
Where
side.
we're going to go is newborn screening of the genome, because there's been a bunch of recent studies. The incidence of genetic issues that are actionable in the newborn screening setting is about 3.8%. That's a lot. And the fraction of those that you catch with typical state-funded newborn screening test is about 1/3. So there's a very good argument for offering whole genome-based newborn screening as the costs come down. And I think that will be the genetics that everyone goes back to through the course of their life. We need to do that right so that that becomes part of a person's medical record for life, and you don't have to keep repeating that. The incredible thing about the timing now is our per capita healthcare budget is about $14,000, $15,000 per person per year. So now you're roughly at the point that you can run a whole genome sequence, just the cost of the sequencing, for 1% of the per capita annual healthcare budget. And from that, we can achieve the most incredible savings in terms of preventative care and identifying the cause of rare diseases and identifying newborn screening conditions based on that whole genome sequence. So the health economic model is very strong. And
when you phrase it like that, it's unbelievable we're not already doing this, because you're saying it's about, depending on the depth read, so how many times the genome's actually sequenced to be confident about each of those variants written down, that's about $100, $200. When you look at anything else in medicine, I mean, anything that's $100, $200 is like, really? It's only that? Like, you walk into urgent care and it's going to be more than that, probably.
Yeah, but when you do something population-wide, you've got challenges. So the cost of the newborn screening test at the state level are tens of dollars. They're done at such a high volume and with such well-refined protocols that those costs are extremely low. But, the costs of whole genome sequencing will pay for themselves dramatically. In the newborn screening context, you're catching all sorts of conditions that can be, acted upon. If you look at the sort of more adult context, you've got the ACMG 3.2 genes, which is a set of roughly 82 genes now, where the positive rate in the population is about 5%, where you really would want to know if you have one of those genes. And then you've got, pharmacogenomics, which is very valuable across all sorts of situations and indications. But the most important thing is we can now build these integrated risk models where you can look at the genetics as well as multiple other analytes, clinical data. You can crunch all of that together with all sorts of AI. So we can build these integrated risk models for disease way better than we could 3 or 4 years ago with these multi-analyte approaches. If we triage people, if we did this for everyone over the age of 35, say, and we triage people to appropriate screening and interventions based on their personalized susceptibilities, the rough health economic models suggest that we can save about $200 billion per year to the US health system. And that's not including all you can gain from increased productivity of the population. So the future is nigh, and there's a lot of money involved if we do this right.
Yeah, that's such a good point, that it's the downstream effect. It's not even just you do this test for $100, $200 and you learn something that you could start preventing. It's more than just one condition that could be picked up. You're looking at the entirety of someone's genetics, and that to keep revisiting that, like, let's say someone has a biological relative that's found to have some kind of variant that causes some symptoms, condition, they could go back to their data and be like, oh, well, do I have that too? And we could just keep going back to that. And that's what makes it awesome.
Yeah. But you can't overstate the value of just the germline genetics, because a lot of the things that make these multi-analyte models work so well is the epigenetics, like the methylation. Then you've got RNA, protein, clinical data, blood analytes, etc. So in order to make a person sort of engaged with their health, you need to have these multi-analyte approaches. That is going to require regular updates with the analytes that are not germline genetics. So although the germline genetics is fantastic, you can't assume that everything can be done without the ongoing monitoring of the epigenetics, the clinical data, etc.
It's really the baseline. It's like the step one of this is really helpful. But what's even more helpful is looking at all these other factors that do change over someone's life.
Yeah, and the power of these genetic models is incredible now. If you focus on the polygenic models, you're starting to see society guidelines change, but society guidelines tend to be about, 4 or 5 years behind the technology.
Easily.
We can talk about where these models are being used in certain indications if you want, and you'll get a sense of just how much you get just from the polygenic germline genetics to sort of augment the clinical models, which doesn't require all of the ongoing measurement of other analytes. So do you want some examples of that?
Yeah, let's get some examples so people can really imagine how this works and get a better feel for it.
Yeah, I mean, I guess I'll pick two examples. One which is sort of considered a phenotype-driven disease, which is cardiovascular disease, and one which is considered a sort of rare genetics-driven disease, which is breast cancer. So, cardiovascular disease was always considered to be phenotype-driven. In other words, you can measure your LDL, HDL, cholesterol levels, your body mass index, a bunch of clinical factors, blood pressure, etc. And you could predict your risk for cardiovascular disease. If you could measure the genetics, it doesn't really matter because all the genetics is upstream of stuff that you can directly measure, cholesterol levels, etc., that directly affect the risk of disease. Turns out that's not the case. If you look at these polygenic models and you combine them with the professional integrated risk models, so you've got, for example, the ASCVD model from the American Cardiovascular Association or the American Heart Association, and that's turned into this model called the pooled cohort equation. And if you combine that pooled cohort equation with genetics, you have a net reclassification improvement of about 10%. So you have all of these nuances going on in terms of a person's susceptibility to cardiac disease, which are captured by the genetics, which we can't capture with the standard clinical parameters that go into the model. And that becomes incredibly important because the ASCVD model, if you look at the population over the age of 50 roughly, about half of that population is going to lie in this intermediate risk range of about 5 to 20% 10-year risk of cardiac disease. And those patients don't have a clear action. Some of them will be put on statins, some of them will be put on lifestyle and dietary interventions, but it's all sort of case by case at that point. If you run a genetic model on that set, you'll be able to bifurcate into those that are above 20% risk and those that are below 20% risk, and you will catch a huge amount of additional disease, patients that should be on statins that are not on statins. And we've shown that this works across ethnicities, to make these models work multi-ethnically as part of the challenge, but they work across all sorts of ethnicities, Hispanics, African Americans, Southeast Asians, Europeans, Indians. So now these models are sort of clinically ready for prime time and make an enormous impact in how you manage cardiovascular patients. So, that's one where the genetics is considered to be upstream, but it's really not. And then there are examples like breast cancer, which, for a long time, people focus on the rare genetics. It's considered to be a genetic condition. You have a BRCA1 or a BRCA2 mutation. And now there's, 50 other genes that are considered to be relevant for breast cancer as well as some other cancers. And that's kind of the most sort of prevalent thinking in terms of susceptibility. Do you have a family history? Do you have a BRCA mutation? Well, the incidence of a BRCA1 or BRCA2 mutation is about 0.3% in the population. The top 5 or 10% of the integrated risk model, which includes the polygenics, that's looking at about 10,000 positions across the genome. The risk for breast cancer is probably the same or higher than if you have a BRCA2 mutation. So without looking at these rare genetic variants on single genes, you're capturing this huge amount of disease load, an order of magnitude more than you can catch with the rare genetic variants. And that's why MyOme is now licensing this integrated risk model through Natera, and Natera is offering this polygenic modeling for breast cancer if you don't see a rare gene, because you're capturing so much more of the disease load that way. And there's tons of examples like this where I think the professional societies are starting to change. I mean, the American Heart Association has started to say how useful these polygenic models are, but there's still some time for the professional societies, I think, to fully catch up with the technology.
Especially because it's taken a while for polygenic risk scores to get to the point where they are clinically valuable. For many years, we were saying, well, they're great, like they will be great. And what you're saying is we're already at the point where, yes, we can start using polygenic risk scores to help us understand people's risk levels for these conditions. So like heart disease, which that's the one I think of most when I'm looking at what can be prevented with some genetic information. And then from that, doing interventions to prevent a heart attack, to prevent sudden death. And breast cancer is such a great example of that as well.
It takes a lot of time to make sure that these polygenic models are ready for prime time. Because it's one thing to publish something in a particular cohort. It's another thing to make sure that that polygenic model works across ethnicities, doesn't have weird border cases with particular admixtures or people who just have some strange genetic outliers, and everyone is admixed. And to get these polygenic models ready for clinical use, it takes time. These are statistical models. If you look at something like heart disease, if you run one model, which is, say, based on HDL and LDL cholesterol, and you run another model which is based on BMI and blood pressure, you're going to get very different results. Those are different models. Now, we've coalesced all of these clinical variables into the best model that we have. And when you have these polygenic models, they're different polygenic models. So you expect to get a different result because they are statistical. The key question is, when you take these polygenic models and you combine them with the clinical models, are you explaining more of the variance? Is it statistically relevant? And there's no question that when you combine the genetics with these polygenic models, you are explaining a much bigger proportion of the variance. So they work with a very basic statistical argument. And you could also say that when you combine the polygenics with the clinical data, you see much less variance than if you combine different clinical models or use different clinical models. So it's all a statistical argument, and I think people miss the point. That said, you do want to make sure that you know what you know and you work multi-ethnically, and there's a lot of techniques to make these models work across all sorts of diverse and admixed people. I would say that MyOme's the world leader at that at this point. So that was the one thing I wanted to say. And then you talked about interventions. I would like to just talk about the incredible thing with diet and lifestyle interventions right now.
Yeah, please do.
Because one of the values of producing these genetic models for people, which is not just about a rare gene where somebody's like, in a rare sector of the population where they've got a rare variant, but the top 5 or 10% of the population based on these integrated risk models. Those people are much more likely to comply with interventions. And when we talk about these enormous savings that we can achieve for the healthcare system, it's largely about how ready people are to comply. And there's a bunch of data showing that when people see their personalized risk based on genetics in particular, they are more likely to comply. The amount of money that goes into dietary and lifestyle trials is tiny compared to the amount of money that goes into pharmaceutical trials, for obvious reason, because you can't make money off the dietary and the lifestyle stuff. But that stuff is like free for the healthcare system, pretty much. So if you look at cardiovascular disease, for example, statins in terms of reducing risk, they're like 31% effective. Guess how effective diet and lifestyle is?
Higher.
When it's properly, when it's properly tested and trialed, it's 46% effective. For type 2 diabetes, metformin, it's like 31% effective. So I think statins is 30% effective, metformin is 31% effective. And guess how effective diet and lifestyle is for type 2 diabetes?
I would say even higher than the other one you mentioned. I don't know, 60, 70. I'm going to go high.
51% effective.
All right. I overshot a little bit.
But that's like actually preventing the disease, or that level of risk reduction. For kidney disease, there's like 40 million people living with some form of chronic kidney disease in the United States. These numbers are insane. And the drugs, the range of drugs, have an efficacy of about 20 to 40%. If you have really thorough diet and lifestyle, those are 68% effective, at least in one significant trial. So the value of diet and lifestyle, if it's thoroughly followed to the health system, is enormous. And a large value of the genetics is getting people to understand their proclivities and follow these dietary and lifestyle intervention protocols, as well as pharmaceuticals.
Yeah, and it's in both aspects. I think with polygenic risk score and looking at what is someone's risk overall to develop a condition or something, right? We want to use multiple tools to assess. So the way that I'm hearing from you is that polygenic risk score should be one of many tools that we're looking to get as complete of a picture as we can, just like on the preventative side and the treatment side, that we want to take multiple approaches. Someone hopefully is not just going to take metformin that has diabetes. They're also going to try to change their lifestyle, if they haven't already, to reduce their risk. You're not just going to do one thing, you're going to do multiple. And I think that's kind of a common thing, that you don't want to just put all your eggs in one basket in that way.
I will stop you when I disagree.
Sounds good. I'll take you up on that. I want to go back to what you said about saving potentially 200 billion with a B a year. Tell me more about this health economic model. How are you getting to that number? Because
crazy, right?
That's an astounding number. I got to learn a little bit more about this.
Yeah, I mean, I'm focused on this now because I'm in a position that I feel I really can make a difference. I feel like I have, I've been involved in transforming, big fields of medicine. And I don't want to just keep doing more innovation that's for the sake of solving local problems or problems that matter to me. I really want to try to solve problems for the country. I'm going through a very sort of patriotic phase, I guess. And I mean that, like, I care about the future of the world very much. And if you care about the future of the world, you have to care about the future of the United States. The United States is the bellwether country of the world. Like, if we can get it together and be strong and have a good direction vector for the world, I think the world will be a very different place. So you can't care about the world without caring about the health of the United States, and you can't care about the health of the United States without caring about the health of our economy and the health of our population. And by the health of the population, I mean, from a national security perspective, people being healthy so they're resilient in the event of, more, pandemic outbreaks, just having a population which is productive and a population which is generating a lot of, gross domestic product, where we want to be strong economically and preferably be saving a ton of money on healthcare and putting money towards other things like AI, hydrogen fusion, that kind of stuff. So all of this for me really ties together. And so I want to work on things where I feel I am well positioned to transform the healthcare system today. And the way we come up with that 200 billion number per year, which I agree with you, it's an incredible number, is you look at the main cancers: breast, colon, lung, and prostate cancer. And then you look at a range of other cancers for which one can offer multi-cancer early detection tests. And then you look at the very expensive chronic diseases and severe chronic diseases. So cardiovascular, type 2 diabetes, and cardio is a bigger killer than all the cancers combined.
It's big. Yeah.
Alzheimer's, stroke, kidney disease, liver disease, macular degeneration, glaucoma, obesity. And that, if you look at the long tail of cancers as well, that ends up being a set of about 27 diseases. If we can build integrated risk models for that set of diseases, and we have a 50% compliance for people going with dietary, lifestyle, and pharmaceutical interventions, by catching conditions earlier when they are way cheaper to treat, and by delaying or stopping the onset of these expensive chronic diseases, you save these unbelievable amounts of money. And a lot of that is not in the cancers. I would say about 75% of that is in the chronic disease setting, where these dietary, lifestyle, and pharmaceutical interventions can make a huge difference to the incidence. And it takes some time for the population to get to a steady state where you've got lower disease burden on the population, maybe 10 years, depending on the condition, where you start to see the majority of the effect. But the effect is just enormous. And the cool thing is, for every percentage boost in these integrated risk models, you would save roughly another $7 billion to the healthcare system by catching more of these conditions for people who otherwise wouldn't be taking the preventative measures. So, it's so exciting. It's something that the future cannot come without. And now we've got the inexpensive whole genome sequencing to actually make that a reality. So that's the kind of stuff that I like to spend my time on nowadays. And, the model's directional. Obviously, there's a lot of details that have to be fleshed out. Largely, it depends on the level of compliance, but directionally, it's correct.
Yeah, it's so exciting just to see how this can have this long-term effect and where that money could be better spent if we don't need to spend it on the other things. And then also just people's lives. Like,
Yeah, having
I
people
definitely am.
happier goes a long way, right?
Right? Like, I can nerd out about finances all the time of just, how to build wealth and all these things. And do I know a lot in that? No, not as much as genetics. Maximizing that and multiplying it, I suppose, by how many people's lives you're affecting and their family members and their caregivers, and they're spending time doing this instead of working.
The loss of productivity, and that $200 billion is really the healthcare system. That doesn't include all of the additional productivity in the population where people are able to be productive for longer and, not distracting with, all of the management of disease from family members and elsewhere. Now, the other example of this is rare diseases. Rare diseases is an incredible set of statistics now. There are like 25 to 30 million people in the United States who have a rare disease. And the diagnostic odyssey, some of those rare diseases, you have treatments and interventions that can really make a difference, but the majority of them you probably don't. But the diagnostic odyssey, I shouldn't say no difference. I mean, you don't have a cure for the majority of these rare diseaes.
Right, but
there are
there's
things that
often
you can do.
some
If
treatment,
you know what's
hopefully.
going on, and it's very idiosyncratic for an individual, but if you know what's going on, there's often stuff that you can do that you will make a difference. But the diagnostic odyssey that people go through when they have a rare disease and you don't know the cause, that's on average about $10,000 or more per person. So that alone is, just gobbledygooks of money.
And how much time
on
that
healthcare
takes. It's usually
costs
7 to 10 years
and
to
the
get.
distraction and the support. If you know the condition, and we've probably got a yield, the rare disease offering that MyOme is about to launch, we've got a yield of probably around 40%.
Wow, that's a lot.
To
Wow.
catch what's going on with these rare diseases. So that can do a dramatic amount to reduce the diagnostic odyssey that families and doctors need to go through. So there's a lot here that can have an enormous impact on both financials as well as life.
This is so valuable for most things in life. It's better to do prevention than treatment. And whether that be getting insurance before you get into an accident, like even outside of medicine. But how do we get healthcare providers on board with actually using a lot of this, using polygenic risk scores more, using let's do a whole genome preventatively? That probably is going to come more from the patient asking for it. But how can we start changing the tides of doing more prevention so that we're doing less treatment? Because you're selling me on all this, but how can we actually get other people on board?
There's no easy answers.
No, that is not a softball question, is it?
You've got to do this the hard way. I mean, you've got to do the clinical trials. And, we've changed a lot of guidelines at Natera. And I expect MyOme is going to be changing a lot of guidelines as well and getting insurance reimbursement, to transform fields of medicine the way Natera has transformed women's health and cancer care. There's no easy path right now. I mean, you've just got to do the heavy lifting. And that includes, roughly 5 publications at least. You've got to be publishing on the analytical validity, the clinical utility, the health economic model, then typically do, some significant level of prospective trial. And you've got to be patient and produce a lot of evidence And there are challenges. I mean, there's a lot of stuff that the private insurance industry is not covering, which is even in their direct interests to cover. You know, you could say that it's based on very cutthroat motives, that they know that some of the testing is going to be provided for free anyway, while companies compete, and so they don't need to cover it, and they can get the free testing and all the health economic benefits in the meantime. But I don't think that's usually the case. I think they're just incredibly slow to act for the most part. And these processes, unless people are really under the gun to take action, unless they're going to be seeing some really serious harms, for some reason, these processes just take a lot of time. And also, you know, on the other side, the health insurance companies see a lot of technologies and a lot of people who claim all sorts of capabilities. And so they've learned over time that you've got to be cautious. You know, I can say a bunch of things about how the system should change, but to be realistic, you've just got to be patient enough to do the trials and develop the evidence. So for example, you know, for cardiovascular disease, we're working with a set of the top health systems in the country right now to show that if you use these integrated risk models for cardiovascular disease and you track patients who get this kind of reporting for 3 years and patients who don't get this kind of reporting for 3 years, that you can show a reduction in significant clinical indicators like cholesterol levels, a reduction in cardiac events, and a health economic model that will actually make sense for the whole country and also make sense for the insurance companies.
If you build it, they will come. Kind of, I think that's kind of the theme I'm getting out of that. Field of Dreams.
Build it and you publicize it and you show how it saves money and you show that it works in every different possible setting, then they will come.
Yes. Well, thank you so much, Matthew. You're such a wealth of knowledge on this. And I just want to also thank you on the behalf of the genetics community that you are doing this hard work. You're making this happen. And we're making a lot of progress in our field of genomic medicine because of the work that you and your companies are doing. So thank you so much for sharing your knowledge and your time with us. And I just wish you and MyOme the best.
Thank you very much. In our next call, I'll tell you what the insurance companies should do and not what you do.
Our dream letter to them, right? This is our demands letter.
That's a less sort of bright-eyed and bushy-tailed conversation. That's more
right. More at them at that sense. Hey, I'm down for it. I think there's a lot of changes that need to happen. So stay tuned, people. That will be our next conversation.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.